Okay, so we're ready to get started. Welcome everybody that's joined on Facebook and also that is registered online. So today we're doing skin cancer training for allied health. My name is Eleanor West. I'm a demoscopist for National Skin Cancer Centres. So what that means is my job is to work alongside the doctors and actually go out, have a look at people's skin head to toe and look out for any signs of skin cancer. I do go out into corporates, so into big businesses and check out all the employees or the local councils. And with that being said, I'm going to share my knowledge with identifying lesions that are a potential risk and just ways that you can refer on. So I'm going to cover what we'll be going through tonight. So we're going to talk about skin cancer and the types that you should monitor and explain to you why you're an important role. So you are essentially going to be lifesavers, and with that knowledge you can pass on to your colleagues, etc. As essentially skin cancer is something that we can see, and it's easier just to pass on that knowledge to people and prevent. So I'm going to explain to you what we do at the National Skin Cancer Centres to help you and your business, and most importantly your clients or patients. I'm going to give you a bit of a plan, so how you can talk to them, how you can establish a protocol within your clinic or business, and also ways that you can share ideas with colleagues and how to approach your doctor. So hopefully at the end of this you take away some information or build on what you already know. So for those of you that are new to knowledge about skin cancer, I suggest taking some notes, or you can always rewatch the recording of this video and hopefully you can pass it on. So we're going to get started. So the first thing is I want to mention that it's very much a highly campaigned thing that there's nothing healthy about a tan. It's because of the way the sun sees us and reacts with UV radiation is something that we can't see with the naked eye. So what we see in this first image is what we see with our eyes. We can't see what UV radiation does until it comes to the surface. And what this is, it presents in a pigmented lesion and like a brown freckle, etc. And the second image is how the sun sees us. So it's basically what's deep down, what's happening within our skin that we can't see. So this is how all skin cancers start. Skin cancers are a form of UV radiation causing damage to our skin cells. So before I go into that, it is really important to note that there are many ways that we can find skin cancers. The first thing is with our naked eye and with questions. And because we can see it, it is the #1 preventable cancer. And what can make you rest easy is that with National Skin Cancer Centres, they do not need to go to their GP and get a written referral to see a specialist. They just need to ring up, make a booking, or best is it can be all booked online as well. So let's go into a little bit of a background onto skin cancer. So what they essentially are is skin cancer is an uncontrolled, abnormal, rapid growth of cells. So what this means is UV radiation has damaged the DNA or the replication process of a skin cell. Therefore, it multiplies in an abnormal and in a way where it bypasses its natural margins and production. So this is where something can rapidly grow or look beyond normal. And so what we're going to do is look at a few different types of skin cancers that we can see with our naked eye, and hopefully it gives you that the clue factors so that you can take that with you. So the 3 that we will be covering, the first 2 are our non-melanoma skin cancers. These are basal cell carcinomas, also known as BCC, from continuous sun exposure. What this means is from daily or long, prolonged time in the sun. And then we've got squamous cell carcinoma, which is an SCC from sporadic exposure. So from like a quick or large or heavy burst of UV radiation, not so much daily, but intensely. So it could be that, the start of every summer, quite a few sunburns, or as a child, a few sunburns, and therefore later in life, higher at risk. So the last one that we're talking about is our melanoma. The big M, this is again from continuous exposure, from that daily UV absorption within the skin. So I will also talk into who is at higher risk as well. So the first one, basal cell carcinoma or BCC, I like to refer them to, as I've written there, as a persistent pink pimple. So a PPP. This presents as a little pearly, could be quite a ruptured, ulcerative little sore on the skin, can also be pigmented, and this makes up generally about 70% of non-melanoma skin cancers. So they're very common. This is because of that continual exposure. So we're talking about areas such as the face, the forearms, the neck, areas that are rapidly exposed daily without protection. So these are really common in those people that, you know, wear a t-shirt and then they might not cover their neck or their forearms and in the car. So keeping in mind that if you do have a client or a patient that has these lesions popping up, that with these persistent pink pimples, they are areas that are exposed continuously. They may be a little pimple that might rupture, heal, and then come back. So it might happen over a period of 3 months, and they are persistent. So they generally come back with a vengeance. So here on the first image, we have a superficial spreading of a basal cell carcinoma. And the second one is a little bit more nodular. So this one would present it as a pearly pink pimple, ulcerated. It kind of looks like it's in the healing stage, but then it'll just go back to square one, if not larger. It can be quite tender. This is somewhere where it's rapidly exposed, which is the nose area, sometimes more so on the forehead. As you could see, this one here, it's easily seen as like a pimple that just won't heal. So this is what we call dermoscopy. This is an image. These are images that I've taken with my scope. The scope allows me to see really close up and see some distinguishing features of each type of skin cancer. So in the first image, it will be very hard to see, but you've got really like a red pink area with some sharp vessels coming up. This is a really small basal cell carcinoma. And then the second image, it's seen a little bit clear, a little bit sharp vessels coming into a little bit of an ulceration. These just look like little pimples. Under closer inspection, I saw that there were some distinguishing features. So to get a very clear diagnosis, I just sent them to book in at the Skin Cancer Centre. Therefore, they could then the next process of removal will be done. So what happens with these vessels is the actual cancer cells itself is growing underneath this, the vascular network. It is pushing the tumour up. So what we see is the inflammation, that pink and that vascularity of the lesion. Nice pearly consistency as well, but you can't see that under the scope. This one here is a nodular scalp basal cell carcinoma. You can kind of see that pearly appearance. This one is on the hair. So this one's really important to take note because I'm going to show you a few that's on the head, neck and shoulders. Is that this is where people generally have like the little crown or areas that have thinner hair, and the hair on our, or the skin on our scalps are really fair. So without wearing a hat or taking caution protecting that skin, it is a high risk area. So take note here, that pearliness, bit of inflammation, a little bit nodular, really hard for people to see. They're more likely to feel it than see it and not really take particular notice on its size. But I dare say hair brushing, etc., would be quite uncomfortable. So this one was, treated and with a complete removal. So we're going to touch now on squamous cell carcinoma, SCC. So I like to then refer these as the triple P as well, as a persistent pink patch. They are generally more of a tender, inflamed spot, and this is from that sporadic exposure. So areas of sunburn. But again, it can occur anywhere on the body, but the most common would be on the arms, face, neck. I have got statistics showing that there's a lot more that show up on the lip and on the ears and then around the nose area. That real thin skin can show up as a pink patch, quite sore, tender, can be quite like eruptive as well, meaning like it will become inflamed, may ooze a little. And these you might see on your clients. They might just look like a pink scaly patch that will bleed and then come back. So once again, very persistent. With that being said, there are things that we call differential diagnosis that look similar to these, which I will touch base on. But regardless of the fact, it's not your job to know 100% what it is. It's just to say, hey, that's something that should be addressed. We'll send you the number to go get checked. It's the easiest way. So here is an invasive squamous cell carcinoma. This is under a scope again. And what we're seeing is the scaly patch on top and a rupture in the middle. This is just a really interesting close-up image. This is one on the scalp. So you notice here the keratolytic or skin cluster on the top, small ulcerations. You can see them coming through here. And it's quite large, so you can't even distinguish the margin here. And this is where it's really important to, as soon as something like this shows up, we suggest that they go and get it addressed sooner, because unfortunately they do leave larger scars than what appears that they are. So sometimes they appear quite small, but you wouldn't even be able to distinguish where this lesion stops and starts. So melanoma, what it is something that we need to get onto really early. So it is something that is more so advertised for diagnosis within the media rather than the other two. Forgot to mention that squamous cell carcinomas make up the other 30% of non-melanoma skin cancers. So when we talk about melanoma, we're talking about a separate case of skin cancer. And so I'll go into further detail and show you many images of these as well. So pink and brown makes you frown, meaning multiple colors and unappealing, very what we call ugly duckling lesion on the skin. Generally isn't just a plain brown color. So as I mentioned before, we're talking about differential diagnosis. So as you would know in your allied health profession, is sometimes something could appear or have the same diagnostic appearance or symptoms as another thing. So what we're looking at here are benign lesions that have the potential to also appear to be a malignant or a cancer. So the first one we're looking at is what we call a solar keratosis, a persistent pink scaly patch. They come in many. One of the doctors says for every one that they treat, there's 100 more that they can't see. It's from long-term sun exposure, many sunburns, many years of sun damage. These will show up mainly on the sun exposed area, so the tops of the forearms, tops of hands, the face, the ears, areas that are always in the sun and come later in life. There is cases where some younger people get them, but they come in numbers with age. The image at the very end, these ones here you will see they look quite aggressive and they feel very odd. So these are what we call a seborrheic keratosis. They appear plaque-like, a bit warty. Sometimes they look like just a stuck-on cornflake appearance or a thumbtack. They have a texture, they have a feel to them. They can be quite dark and aggressive in appearance with colour. And then you've got like the pink, more skin-toned. But the thing is with these is they are benign, but again, you're not to really know, so we would suggest to refer them on. But if this is something that you're seeing on people or have recognized, you probably have the like that distinguishing visual aspect of it being very aggressive looking, because they generally come in numbers. The most common on the back of people, under the bra line, on the shoulders, etc. So we're going to go into some melanoma images now. So I want you to see if you can find this. So one image is of a man's arm. The second image is of the dermatoscope, the image, the close-up, what we see with our scopes. So if you can see it, see if you can pinpoint it, it is very small. So this one here that we're seeing breaks the rules of the 6 millimeter indication for melanoma. It is very small. It is a dark pinpoint. So this here. So this basically shows that on this man's forearm, you can see that there's not many lesions, but this one here was a real standout. It's what we call an ugly duckling or an elephant in the room. It just catches your eye. So a lesion like this, when I would do a full skin check, it will jump out. Although I'll check most lesions, it just doesn't look like it's meant to be there. And it is the potential melanoma. This one here is a class A of an ugly duckling or elephant method. Okay, it's very obvious. It's got a lot of chaos in there. And with this one, I just immediately gave them the suggestions to ring, and they got in within the week and it was successfully treated. So this is a melanoma that was growing for 3 years. It was spreading. We got it just in time for it before it became quite a problem. So what we're seeing in the pink area, I've got it zoomed in, is this is a sign of regression, where the pigment is regressing and moving inwards, or the immune system starting to try and attack the lesion itself. You can also see some grey, blue, white veil. This is a very aggressive sign. We're seeing the pink, the black, the brown, the blue, all the colours that we don't want to see together. So generally a nice healthy mole will be one colour in a nice beautiful pattern, whereas this one's is full of chaos. You can't see where it stops and starts, where the colours are meant to be. So this one here is a 65-year-old man. It is an early stage melanoma in the sideburn. You can see here when the close up through here, you can't see where the lesion stops and starts. Same with here. So it's quite a chaotic lesion. It's got a bit of pink, brown, black, and it's hidden. So it would have been very tricky to see. And again, these ones here, if you're within the industry where you do treat people quite closely and you're able to see these lesions, it's harder for them to see. You're going to see areas of their body that they don't see every day, or their partner may not even see every day. So I definitely suggest them taking a closer look. This one here is another truck driver, a picture of a temple melanoma. He went into the clinic and said, is this a melanoma? And then that's how he got it checked, because someone pointed it out to him, and then a close look. What I want to point out here is, again, an ugly duckling or an elephant in the room. It does not match his skin recipe. It's sitting there on the temple. It doesn't look like he's got anything remotely similar in the area. So it's not like a common thing for him to have moles or spots and dots on his forehead, face, or hairline. So it stands out. This is a 23-year-old, it's a skin type 2. This is a rapid growing, very small melanoma. Similar to the image I showed you before. As you can see, stands out, does not match her skin recipe. We'll go further into what a skin type 2 is if you're not aware. It just basically means she's a very fair skin, very susceptible to sun damage. But as you can see on her face, neck, from the image that we're being provided, is that there's not a lot of clues saying that this is normal for her. So when it was checked, it was then distinguished as a rapidly growing small melanoma. So these are the 5 signs of skin cancer, where these are more tailored to the melanoma. So I will go through the A, B, C, D, E very closely now. And I'll give you a bit of ways that you can address this with your clients as well, or your visual tools. So the first one is A, so asymmetry. So if something is symmetrical, one side matches the other, you could cut it in half, and you can't distinguish one side to the other. So picture a pizza, asymmetry, you would cut the pizza even into quarters. One quarter doesn't match the next, etc., etc., etc. So it's saying that there's no way that this is a good looking, even lesion of the skin. It's quite different from each aspect. So one corner to the next, or one half to the other. So if you were to visually see this in someone, you'd see maybe two totally different carpets or rugs stitched together, and it looks very odd. The border. So B meaning the border around the lesion itself. Is it nice and smooth with nice even edges? Not all moles are circular, some are oval, some are very oblonged, but it's nice and even. You can see where it starts and where it stops, and it's quite consistent throughout the lesion. As you can see in the second image here, the border is very erratic. You don't know where it stops, where it starts, which one's blended in. It's quite almost like a smudge or a bleed within the lesion. C stands for color. So as we've seen in a couple of images of melanoma already, it's not just pink and brown. It can be a blue, grey, black, a blend of all of them. Could be a blend of two. What we see with the nice healthy molars might be all brown, but it may be different shades or different textures of brown. And then when we see something that could be more aggressive or malignant, we're seeing maybe different shades of brown in conjunction with pink or grey or blue, etc. And then you can also see that it looks really chaotic in the second image there. Multiple colours, the border's all wrong. It's not of an even symmetry either. And diameter. So I showed you an image of 6 millimeter break the rule with a man's elbow. It was about, one on his elbow was about 3 to 4 millimeters. So what it is it's generally the end of your pencil is a 6 millimeter diameter. This isn't always the case. So if something is smaller and it just doesn't match its area, we always suggest to get it checked. Or when it's about 6 millimeters or more, we're able to see those distinguishing features such as the border and color. So the diameter is definitely an important aspect of identification, but it's not the most important. This one here is what I'd say is one of the most important. This is the evolving, or what we call the evolution of change. So for example, the symmetry, the border, the color is changing week by week, month by month. Is the lesion changing in regards to its texture? Is it bleeding now and it wasn't 2 weeks ago or a month ago? Is it now crusting over and getting larger? Is it causing discomfort, whereas it once wasn't? Is it starting to regress and appear to be disappearing? These are those things that we like to ask the questions of. When did you notice this lesion? Have you noticed it change in the last week to month? So an important thing to know is, let's say someone is in their mid to late 30s, they come in and they're like, oh yeah, I've had that mole, but I've had it as a teenager, but it looks aggressive, but it actually hasn't changed in the last decade. It's a very got a nice border. It's brown, but maybe variations of brown. We would still suggest to monitor it, but a melanoma starts its life as a melanoma, not an adolescent mole. So keep that in mind. It's definitely not your or my place to tell someone that no, it's nothing to worry about. But we definitely suggest they just monitor it and see if that evolution is happening. So these are the harder to find melanomas, and ones that if you are in the industry where you are seeing different parts of their body, so again, hands, feet, these ones are what we call acral melanoma. So the first one's within the fingernail. And the fingernail has a little white half moon. It's called the lunula. The pigment's running up and through the lunula. It's generally a sign that we don't want to see, and we suggest straight away it gets a check or a biopsy or a complete removal. If someone has trauma in the nail bed and then that bloodline grows out, that's a positive. If it's in continual growth, it means there is a melanoma within the cutex or the nail bed. Second one is an aggressive melanoma on the foot. How chaotic does that look? You don't know where the border is. It's definitely not symmetrical, multiple colors, and it's probably changed quite rapidly, but hard for someone to see. It's at the bottom of their feet. And then this one here is between the toes. Again, don't know where the border is. It's quite an odd shape. And there's many different aspects to it. Okay. So here we have, I did say we'll see many on the upper body, so the head, neck and shoulders. This one here is of the ears. So here we have something that does stand out. It's quite irregular in shape here and in colour. I would, if I saw this, I'd say, off you go, get that checked. It's really hard for someone to see that part of their ear. They may be able to feel it, may get quite tender. So it is something that needs to be addressed very soon. Within the scalp here, so while the wife was cutting his hair, she noticed that this one, it may have just been a common, started as just a normal mole that she may have thought, and then each time, you know, how I'm not sure how often a man would get his hair cut by his wife, but let's say she did notice it starting to change. And wives are really important with this because they push until they get it checked. I have many cases and stories of these. And so this man was lucky enough to get it addressed quite early. So if you're starting to see things on clients or patients, let's say you see them monthly, 6 weekly, even 2 monthly, just keep a mental note of some spots and see if you even see a change, or suggest they get it double checked before they come see you again. A little background story with this man here. He was a previous melanoma patient in another country. If you see my mouse here, this is actually the scar, which is a little bit pigmented where the original melanoma was removed. Then he noticed within several months before seeing me that this spot here showed up, and he said it was growing. Now, close look, it doesn't stand out like an elephant in the room to me. Because you can see he's got a lot of sun damage on his shoulders as is. Then this one pops up, and I look at closer. It's starting to look a bit grey, a bit blue. It's got chaos. I don't know where the lesion stops and starts at a closer look. So this one was in, I just wrote it down for him where it was, rang the clinic to just pass on details. He then rang up, booked, and had that sorted. It was biopsied. I'm not quite sure of the outcome, but because he was a previous melanoma patient and it is within the same area, he said it looked very similar to the original melanoma. It was something that we wanted to address really, really quickly. This is a picture of a melanoma on the scalp. Again, was found when was getting his hair done. That doesn't look too done there. He's quite a young man. His wife found it again. So this is really important, where people generally themselves won't do something about it until they are suggested by someone else. He is an outdoor worker and most likely did not wear a hat. He would have had definitely continuous sun exposure in this area. You can see how fair the scalp is, but take a notice on his body. He's got a fair few moles. This is probably where he was just used to being someone that was with many moles, therefore it was no surprise to him. But then looking at the closer lesion, it's definitely not a symmetrical lesion. The border is quite chaotic and the colors are all mismatched. It's not a nice, even honeycomb appearance. So this one here would have been addressed quite quickly. All right, so not every skin cancer has a happy ending, but this is where we learn from them. This is a young female. She came into the clinic where the doctor that she saw asked how long or when did she notice it. She said she noticed it at Christmas time, and it wasn't until end of June or July that she then came and did something about it. Unfortunately, this person did succumb to the melanoma and passed away. And this is quite unfortunate. This is why we are really important within the allied health industry to see things earlier and encourage people, even if it is nothing. We hope that you never set your eyes on a melanoma, but if it is something that you do see, that it is very important that you just put that suggestion in that they get it checked. 7 months is far too long. There are cases that I've shown you that have taken 3 years, but not every skin cancer grows the same as the next. Some are very aggressive very early on. So looking at the image there, you can see that there's a bit of an ulceration, a bleed here. You've got the blue, grey, white veil. You could probably see where the original lesion started to grow and it rapidly changed. So within 7 months, goodness knows what it looked like in December. But let's prevent this from happening. Here's another story. One is a differential diagnosis. One is a potential melanoma on this man's back. When I saw him, I was like, oh, you don't have too much sun damage. He's a very fair, freckly person. Then he had one lesion here, which had a really odd texture to it, color, uneven shape. And then the second one was what we call that seborrheic keratosis, where it was the plaque-like, dark, odd-looking lesion. Therefore, in my head, I'm like, these two look similar with the naked eye, but upon closer inspection, they're actually very different. It was the man's first skin check, so without even hesitating, I said, "Oh, this one here particularly definitely needs a double check," and we both rest easy that night. It did get biopsied, and I'm yet to hear what the results are. So just some facts just to refresh your mind before we get into some more images is approximately 2 in 3 Australians are diagnosed with skin cancer by the age they're 70. It's actually starting to lower. That age is starting to lower. And it's probably because the generation, like I know with my parents, is sunscreen wasn't always the best option. Maybe it was baby oil and the tan was the best thing going around, or it just wasn't a very nice, like appealing cream to apply because it was thick. So these people, these generations, so I reckon between 50 and 70, we see a lot more coming in. So hopefully by the time the younger generation is that we start to see a lower diagnosis of skin cancer. So more than 750 Australians are treated each year. This is the combination. Again, remember that there are basal cell and squamous cell, and then we've got the melanoma. There's several types of skin cancer. I'm just touching base on the ones that we more readily see and that you might see as well. So melanoma is the 3rd most common cancer in Australia, and we could probably, without even hesitation, link this to our lifestyles. The outdoor lifestyle of enjoying the sun, enjoying time outside, the outdoor work here, and also our climate. So we've got those beautiful beaches. Not only that, is Australia is a big farming communities out there as well. A lot of outdoor work. So we can definitely go hand in hand. So let's touch base on some more visuals, because I know myself, I prefer to see things and learn visually what I could see out in the workplace. So this is a 70-year-old cyclist. So picturing melanomas, you know, they're from continuous sun exposure. You could probably see there very clearly the line where he would have had his cycling shirt, and then only every now and again get some damage here. So looking at the elbow, oops, sorry, I'll go back. Looking at the elbow here, you can see the lesion really clearly. It's an elephant. It's quite a chaotic lesion compared to the environment. You can see a lot of sun damage there. I'm sure he has other potential skin cancers within the area, but with the naked eye, this one stands out. It's under closer inspection. You can see the chaos and the clues there. So we're looking at the border is irregular. The diameter is quite large there as well. We're also looking at the color, and it's probably evolving quite rapidly as well. You probably didn't notice it. And again, I'm not quite sure of what stage this skin cancer was, but it was addressed quite rapidly once it was found. This is a really odd one. This is a mother in her mid-30s who has a malignant melanoma. It is quite small, but then looking at her skin recipe, you can see in the areas that she does have a few moles, but they look like they've been there a while, but this one was new. And the important thing to know is if you are in your 30s or you have a client or a patient in their 30s and they get a new mole, again, new moles, we don't want them. Moles that you get in your adolescence, they generally don't have the opportunity to change, and they will always be that. But anything new and rapidly growing, we get addressed quite quickly. This image I took last year. So I want to just touch base with you is just because an area doesn't see the sun a lot doesn't mean you can't get skin cancer. Skin cancer is skin cancer. Wherever you have skin, you can get skin cancer. So this one here is in the corner of the eye. So eye protection. So sunglasses really do protect your eyes. And this one here was really tricky. She noticed it, and it was only fairly new lesion. I couldn't get a close enough look with the scope, so I referred her to an ophthalmologist. Now, this is a specialist. It is something that I did get advice from the doctors that I work with, and they suggested it was also probably too hard for them to address due to the sensitivity of the area. So then it will be referred to a specialist, and then it was addressed from there. I'll be very interested to see what the outcome is, but just to show that you can get pigmented lesions in areas that don't necessarily get sunburnt. So have a closer look there. There was variations in brown, but because of the natural pink area that it was, I wasn't able to see any other color features or diameter there. Another ear lesion. Just pointing out here with my mouse that this is actually a very large lesion, but you can't actually see or distinguish its border. It's got very odd colours involved there. It almost just looks like speckles or like pebbles of colour popped together. Again, very hard to distinguish, but if you notice it, just give the suggestion of getting checked. Okay, this is really interesting. This is only a recent image. This one here is of someone that did have a very, very large melanoma found within the year of me taking this image. And then this is within a tattoo. So this is where it gets really tricky. Wherever you have skin, you can get skin cancer, regardless if there's a tattoo in there. So if you're seeing someone with a tattoo, but you can actually see lesions popping up, or it's harder to see. And so this here is of it's a fairly large image, lesion, but it was addressed quite quickly. It was removed. Unfortunately, the tattoo was damaged, but happy days. It was a benign lesion, but because he had a history of melanoma, it was really important to take all lesions very seriously. Another ear. I want you to take note here that it does stand out. You can see that there's no other lesions in the area. It does look circular, and it does look smaller than 6 millimeters, so maybe something that would have been brushed off. But the doctor did take a closer examination and noticed that the chaos and those clues were there and was since addressed. So let's brush on some more facts. So 12,744 Australians were diagnosed with melanoma in 2013. So what the majority of the skin cancers are caused by the sun. People say, well, what do you mean by the majority? I thought all skin cancers are caused by the sun. But there's another device out there that does emit really strong UV, and this is our sunbeds, so our solariums. These are the other causative or very high risk factors if people are using them. So unfortunately, I don't have new statistics or research in regards to updated melanoma diagnosis up to 2020, but this is really interesting to keep on track. Keep the research out there. It is really important for every person you refer. It adds to the statistics, and we're able to save more lives. So hopefully the next presentation is I have updated statistics for you. So non-melanoma skin cancer is more common in men and almost double rather than compared to women. And this is probably the close link to the lifestyle factors. So the outdoor, most likely to be outdoor workers, long haul truck drivers, people working the land, so farmers. I see a lot of truck drivers, I see a lot of, and yes, I do still see these in women, but not as in greater numbers. So if you're male and female patients, treat them all the same, keep an eye out, but you keep an eye out for those people that are outdoor workers. They are a high risk group. So let's talk about the people that are at risk. Just keep this in mind that it doesn't work for everybody, but some people bend the rules. So the first one is fair skin. It says it. They're someone that's easily burnt. These people turn pink at the sight of sun or the thought of sun, and then they may peel and then go back to white. Red hair or fair hair, so blondes, or people with generally fair eyes. So talking about fair genetics, it puts them at a high risk. Experience short, intense periods of UV radiation. So intense meaning like no protection, out there, hot sun, nice pink skin. So people that are wanting to get a tan or use a solarium, these are high risk, because I believe that fake it rather than bake it. It's a lot safer. It may not be as appealing or last as long, but it's definitely going to save lives. So actively tan or using solarium. So these are people that would do it on a regular basis. And again, as I mentioned before, people, the lifestyle or work life of outdoors. Now, weakened immune system, keeping in mind that our skin is the largest organ, and that organ has its own immune system. So I will go into how that immune system kickstarts when it sees the sun. But if your immune system is lowered due to radiation or for cancer or other illnesses, it can suppress your skin's natural default to protect itself. So talking about skin types, earlier we showed you a picture of a girl with a rapid growing melanoma on her neck of a skin type 2. So categorizing her as a fair skin type, but not as fair as a fair-eyed redhead freckles. And then it's just basically putting people in categories. So the higher the skin type, or what we call Fitzpatrick skin type, the natural protection that skin is going to provide due to its natural composition of melanin within the skin. So these people don't, those fair people may not be able to produce as much melanin as those that are of a higher Fitzpatrick. So therefore their skin isn't able to protect itself for a period of time. So this person here, I will go into this image, but let's just go through some people more at risk. So people that have multiple moles on their body, this is because it's probably hard to see new ones that come. They just blend into the ones that are nice, generic, adolescent moles. New ones may pop up. Dysplastic nevus syndrome is what we're seeing here in this image. A personal or family history of skin cancer. So if that person, like I showed with the tattoo, had a melanoma that year removed, is most likely or a high risk of getting another one. Or a family history, talking about mother, father, brother, sister, not auntie, great-grandfather, etc. It is generally a close linked family. It's basically around the DNA or the way your skin is responding to the sun. It is a small percentage, however, there is a genetic link there. So back to that image, this person here has many hundreds of moles on their body. At a closer look, these moles are very symmetrical. They've got a beautiful network of color. There may be variations of brown, but generally all very good. Then we have an example where a doctor last year removed one just for the sake of just having a biopsy, just to distinguish that yes, this is a mole. Just to find that yes, it was a benign lesion, left a nasty scar. And this is where a skin cancer professional, such as the ones here at National Skin Cancer Centres, their eyes are directed at finding those clues and the chaos. So it saves people from having multiple scars. This was done at a GP clinic. So the sooner a skin cancer is identified, the less likely people are going to be left with scars. And again, like that image that I showed you, we do not want it resulting in death. So even if something doesn't sit right with you, we are referring. We are suggesting to them that they go get a skin check, head, shoulders, knees and toes. It's done once a year. If something is found, it's treated generally very rapidly and quickly. And I will go through that process with you so you can explain to people as well. So things for them to keep an eye out is it changing in regards to the way it heals? Is it crusting and is it persistent? Like I said before, is it something that is just healing and then comes back with a vengeance? Is it ulcerating and it, you know, may get bigger and sore? Are the lumps getting larger? Is the color changing? Is it very pearly? Are they quite tender? These things are distinguishing features that aren't necessarily the only thing we ask for, and not all lesions are tender and ulcerate. But if someone was concerned with something, I would drop these questions just to see if I can get a clear response of what it could potentially be. So in regards to a mole, you know, is it new? So are they within their late 20s, 30s, 40s plus getting a new mole? Is it changing? Is the color, the shape, the symmetry changing? How long have they noticed it for? So talking about with sunburn, the sun definitely causes 95% of melanomas. This is statistically proven. We then always think, oh, I only got 1 or 2 sunburns, so that is definitely enough to damage the DNA network of the skin. So sunburn is even common on those days that are overcast, so we're like, oh, I don't need to wear sunscreen today. I think that if it's daylight outside, no matter how dull of a day it is, there's still UV. It may be significantly lower than what it would be in a summer day, but there's still UV. I bet there's many of us out there tonight that have experience of getting a sunburn sitting in the shade or on an overcast day, even just in the garden. So sunburn, it doesn't always have to result in a peeling or a blistering endpoint to be dangerous, but it does, what it does over time is it UV radiation, ultraviolet radiation, over time will damage the DNA within that cell of how it replicates. So that rapid and that intense radiation is dangerous at no matter what level. So tanning, we've all heard this, there's nothing healthy about a tan. In Australia, it's very culturally accepted to have a really beautiful sun-kissed look or going on holidays and coming back gorgeous and brown. I'm not gonna lie, I think that's a beautiful look as well. It's not for everybody, but I'm thankful that I have a good friend that can spray tan me. So I just want you to take note here, people that lay on their tummies and they do wear sunscreen. If I asked 100 people specifically where they put sunscreen, it is very unlikely that they will mention the bottom of their feet. And this is where those acral melanomas will start to come quite common. Acral melanomas within the nails and the bottom of their feet are very common in those darker skin types. So where we're talking about skin type 4, 5, and 6, where that is the fairest, least protected area of their skin. Remembering wherever you have skin, you can get a skin cancer. So tan, your natural tan only equates to about SPF 3. So about let's say 5 to 10 minutes of natural, like light UV exposure. Not very much at all. So any form of browning is an indication that your skin's immune system has kicked in. And so what a tan is we have cells called melanocytes. These produce melanin, which is the brown of the skin. UV radiation is absorbed. It triggers the response of the skin to protect itself. Therefore, the melanocyte produces more melanin. So tan is an indication that UV radiation has been triggering the skin to try and defend itself. And over a period of time, it can only have so much effect before the skin cells start to change. So the commercial use of solariums is now banned in all states of Australia, making it illegal to sell sessions or provide this service. So it causes a very high and intense delivery of UVA and UVB radiation. Both radiation waves, so ultraviolet A, ultraviolet B, have been known to cause cancer. So people who use solariums before the age of 35 have almost 60% greater risk of melanoma. And this is probably why, before it was made illegal, that those people that used to go 2 to 3 times a week, even once to twice, now later in life are finding melanoma, even in those areas that didn't get that continuous sun exposure. Because in a solarium, they generally lay naked. We've seen skin cancer in areas that don't see the sun. So just touching base before, mother, father, brother, sister, if they have had a diagnosis of melanoma, it is highly suggested that those people also get closely monitored, even at a yearly basis. I would suggest people at a young age to just get a skin check and then follow the doctor's advice of how frequently they should come. So let's say that a mother, father was diagnosed with melanoma. Sometimes as people as young as 16 may come in for a skin check, and then it's recommended by the doctor that they may come every 2-3 years from there. So just touching base on the campaign of the slip, slop, slap and seek some shade. So slap on or slip on some long sleeve protective clothing or long pants. This is more so if you're going to be outdoors for a long period of time. Slop on some sunscreen. The recommendation is 20 minutes before sun exposure. The reason being is this is because the UV rays are absorbed really quickly in the skin, but sunscreen takes up to 20 minutes to have a full effect. So chemical sunscreens are absorbed by the skin before they're able to give you any protection. for 20 minutes, and they're there for every 2 hours or after any swimming, water exposure, sweat. So these are some things to touch base on when you're looking at a sunscreen bottle. You want it to suggest UVA, UVB clearly on the front or stated on the front. So UVA radiation penetrates deep into the skin. I like to refer to UVA as UV aging. It causes damage to the collagen and elastin and also the DNA aspect, as I've mentioned many times before. Then we've got UVB radiation. So it's the more superficial radiation of the skin. So UVB, I like to refer to UV burning, so causing the burning change in the skin, that pink, that inflammation. So what broad spectrum means is both UVA and UVB protection. So by applying 20 minutes before you go outside, you are protecting your skin from triggering that immune system. So you do need to apply the correct amount to have that full protection. So it's about 35 mils per limb. So we're talking arm, leg, and about a teaspoon for each leg. I like to say, you know, like you shouldn't be skimmed on sunscreen. Make sure it's all rubbed in easily and nicely. Make sure you buy one that suits your skin if you like a lightweight one or a heavy cream. Although I do have a suggestion when it comes to aerosol sprays. It is unlikely to get the full dosage you need per limb when using aerosol, as it's a very thin mist. So I would suggest people just use this as a touch-up or to fill in areas or get to hard-to-reach areas. So slap on a hat. We've shown you many images of people with skin cancer on their ears, tops of heads, and the neck. So what this is not being protected from the sun in these areas on a daily basis. So a hat is one of the most important things. So seeking some shade, wherever there's sun, regardless, there's always going to be UV radiation. However, it's significantly lowered in the shade. So slide on some sunglasses. So I showed you an image of someone with a potential risky lesion in the corner of their eye. The way we can prevent this is through eye protection. This is something you can find on the Cancer Council website, or it's actually something that might be within your smartphone as well when you're checking the weather, is the UV index. What a UV index is it gives you a clear indication of when the highest risk of sun is during the day. And as we probably all know, it's during the middle part of the day is the hottest. So the best time to do your outdoor activities is in the early hours of the morning or in the evening. So from 4 p.m. onwards, or from 6 till 8 to 9 a.m. in the morning. For those that work outdoors, these are the people that are exposed during the day and the highest risk time. So this is where they need to slip, slop, slap, sleep, shade, do all those preventative measures. So to self-examinate, this is how you or your partner can check each other, or how you can suggest to your client or patient how to go about it. So regularly check your skin, do those 5 signs, A, B, C, D, E. Does it change? Or get partners to take images, or suggest to your client or patient they get their partner to monitor if it's on their back or their leg prior to seeing you again. So the high risk groups, outdoor workers, long haul drivers, I've touched base on those fair skinned individuals, those immune compromised people, and singles, so people that may not be able to see parts of their body, and statistically again more males than females. Winter is the best time for these people to get their first skin check. So this is why I'm really happy you guys are getting this education today. So you can start this process and get these people in. It allows time for a biopsy, so where the lesion may be checked to heal. If topical treatments are needed, it's a lot better healing time, and it's less exposure during winter. So here's another image here. This is a nodular basal cell carcinoma on the scalp. It is quite pigmented as well. This one was removed. The image that you see with the skin pen is the ellipse, or the excision site. Another melanoma. Looking at this one, you can see quite clearly that it is an elephant in the room, or an ugly duckling. Does not match her skin recipe at all, having a closer look here, you can see that she's actually of an olive descent. She's a Greek lady that noticed this mole. New one, she was in her 50s. It then got checked. It did have a happy ending. It was removed successfully. This is an older gentleman. This is the lesion here that we're looking at. Looking at the chaotic clues again, this one was going for 3 years. You can see pink, we can see the brown, we can see the black, the blue-grey veil over the top. Chaos needs to go. If I saw this on, let's say I was a massage therapist or a physio and I saw this, I would definitely find this quite suspicious. It is very hard for someone to see that. Nearby, we've probably got something that is that seborrheic keratosis, more like that plaque, warty-like lesion. Again, a differential diagnosis. It would be hard for a wife or a partner to say, oh, yeah, I don't know, it's been there for 3 years, it looks fine. It is, if it doesn't sit well with you, refer it. This is an interesting one. This one here, you can see clearly the lesion that I'm pointing out. It looks quite chaotic. It stands out. This person is of a darker skin type descent, and it just didn't sit right with me. I took a close-up image, sent it off to the doctors. I got a few suggestions, and we did get this person in to have a closer look. It didn't become, it actually was a benign lesion, but you could see how I just was not, it just wasn't sitting well with me. So he made the phone call, booked in and got it checked. And then we both were able to rest easy after that. So the questions that you should ask: is it itchy? Is it sore? These are things, is it persistent? Like, is it healing and then coming back? Does it bleed? So ulcerate. Is it not healing? So it's persistent. Has it changed that in that shape and the color and size? So the evolution. And does it look different to everything else? Does it not look like it suits its environment? Does it stand out? So prevention is key. So it is conducted by trained clinician like myself or a specialist at the National Skin Cancer Centre. It involves us using a handheld device called a dermatoscope. We have a look at all the clinical features at a closer range. So we check head, shoulders, knees and toes. We do check all areas of the skin. So I check eyes, lips, nose, etc. So head to toe check. I'll just share, this is just a really quick 10-second video. This is just how I conduct it. Have a close look. It is something that I am quite particular with because you just don't want to miss anything and you want to make sure that person feels really comfortable. So we always make sure that that person's covered. We use a courtesy cover, and it's only done 20 minutes once a year for those people that just want a check. So this is the dermatoscope. We are able to see the close-up clinical features, and it also allows us to take images. So this is what we see with the naked eye. This is a melanoma above a nipple of a man. We showed the area, had a look. It looks quite chaotic with the naked eye. This is what it looks like on a dermatoscope. We can see irregular border, not symmetrical, changing color. I don't know how quickly it was evolving. So the process that we take is we monitor. Monitor being that we have a look. If it's suspicious, we biopsy. And then from there, we would refer if it needs a specialist or it needs other treatment. So we take the images, have a closer look, keep it on the patient's file, or we get a second opinion, or mole mapping images may be taken. So we take a biopsy. This one here is a punch biopsy. It takes the thickness of the lesion out. The area is numbed prior, and this will take the full thickness of the skin lesion. This is a shave biopsy, so the surface or the whole lesion may be taken to be sent off. Once the biopsies are done, it's then sent to histopathology. We then get a very clear report back of the type of lesion it is, so it's full diagnosis, how deep it is, and to the extent of what the treatment needs to be, or the margins of removal that need to be taken to create a safe, successful removal. So then the results are then given to the patient, and then their options are given to them with treatment. So, okay, we've removed the entire lesion, or more measures need to be taken, or more monitoring needs to be done. So the process such as cryotherapy, liquid nitrogen, we may freeze the lesions off. Topical treatment, these ones are ones that burn any precancerous cells within the skin. Surgery, so the removal, or we refer such as like a like ophthalmologist or a plastic surgeon if it is quite a tricky lesion. This is an example of photodynamic therapy for a basal cell carcinoma. So it was a topical treatment, then treated with photodynamic therapy, which is actually a form of UV to treat the lesion. So it actually causes what we like an ulcerative burn, but it kills all the cancerous cells there. This is a better option for this man, as thin skin around the nose, surgery wasn't the best option. It is then followed up. If they do get diagnosed with a skin cancer, they then get checked every 3, 6 or 12 months according to their diagnosis. So key points to remember for your safety and your clients: if it changes, make the phone call, get them to book online. It's really simple. They don't need a referral written or anything like that. They don't need any form of documents with them. They just need to have their Medicare there. It is Medicare rebated as well. Catch skin cancers early. Skin cancer is the only skin cancer we can find with our eyes. So you guys have the power now to potentially save lives. If it doesn't look right, if it doesn't sit well with you, it most likely isn't something very nice. Send them on. Get that suggestion, pass on the phone number, and we'll go from there. So some suggested protocols: use calm language. So never go, oh, that looks really bad. We want to go, okay, this one here's fairly new. I haven't noticed this last time you came in. I'm going to just give you a number just so you can get that checked. Just so next time you come in, we're aware of what it is. And I know if I can look out for anything for you. It isn't your job to diagnose. It's not your job to say that looks like a melanoma or that looks like this. It's your job to just keep in mind the diagnostic tools and give suggestions. You might like to keep in touch with the client. So if you see them regularly, or if you don't, ask them, you know, how'd you go with getting that checked? Was it anything that you need to worry about? Would you like me to keep looking out of things for you? The best thing you can do is refer and give them the number and the contact to go see us at National Skin Cancer Centres. It's a really easy process. And the other thing is have that system set up within your clinic. Talk with your peers and your colleagues. Say, hey, this is what I've learned. What I'd suggest is we write down a protocol. It's if we do see something we're unsure of, this is what we say, this is the number we pass on, and this is how we follow up. Okay, so our purpose is to save lives through education and easy access to diagnosis and treatment. This is the best way we save lives, and we make it comfortable for you. Lovely to see you all, and we're going to go from there. See you.